Hi, I'm Dr. Celin Gelgec.
And I'm Dr. Tori Miller.
Welcome to Breaking the Rules.
On Breaking the Rules, we talk about all things OCD.
Obsessive compulsive disorder, OCD, impacts up to 1 to 2% of the population. We are here to provide not just education, but to inspire clinicians, families and people who are impacted by OCD to be able to access the treatment they need in order to get better.
Catch us every fortnight, wherever you get your podcasts.
All right.
Hey, mate.
How you going? We have a new set.
I know.
I feel like we have to address the set. It needs talking about. It's too good.
I'm obsessed with this set.
So what do we have on our set? We have all things triggering. We have on our table some Tori's dirty lipstick. No, it's not Tori's, but
who knows whose dirty
who
lipstick
knows
that
whose
is.
dirty lipstick and dirty tissues that is. We have some sticker letter thingies.
Yeah.
To
Just general mess.
General mess, some numbers, which we have on our shelves behind us. We have may or may not be blood-filled syringe. We have some poo. We have some syringe containers, some eyeballs with some knives. We have kids' clothing and some sleep suits, some kids' formula, some baby wipes, some vomit bags.
Triggering words.
Yep. We have a dirty mirror. We have things out of order. All sorts of things. Hopefully lots of triggering things for you to practice a little bit of exposure while listening to our episodes.
Yes.
Yeah. And if you're not watching and you're listening, please head over to YouTube and hit that subscribe button.
You sound like my kids pretending to make YouTube videos.
And our coffee has arrived.
Thanks, mate.
Thank you, Tully.
Yum, yum, yum.
So good. And give us some love because that's how we'll grow.
Yeah.
And if you want to keep hearing us and listening to us and watching us, save, share, like subscribe. Got that down pat. What are we talking about today?
Oh, sex. Yeah.
You did it.
Yeah, talking about sex. So
we're going to go there.
Yeah. So such an important topic for us to talk about, which is sex and OCD.
Yes.
For so many reasons. So for those of you new to the space, sex turns up in so many aspects of OCD, the OCD experience for clients and therefore for clinicians.
Yes.
So it is partly about the sexual themes that people experience, right?
The taboo themes.
Yep. So that can literally be anything, right? But sex is so often incorporated, right? So it could be quite literal. Very common one is sexual orientation OCD.
Yes.
We have things like
bestiality.
Yes. So the fear that or the thought that you might want to have sex with your animals, with your pets, or perhaps the fear that you did and you don't remember. Incest OCD. We've talked a lot about pedophilic OCD, which we will keep separate because we've done a lot of talk about that. And also even just things in relation to contamination fear around bodily discharges.
We were talking earlier with our producers around worries when people get intrusive thoughts around masturbating and then did I fall pregnant? Or even just sharing that space and not actually having intercourse with a partner but being intimate in other ways and worrying about pregnancy and that sort of stuff.
Or sexually transmitted infections. So the health sort of themes coming through as well in relation to sex and then also like in relation to the relationship OCD theme, we've got people who are worried about infidelity, whether they have, cheated on their partner by having sex with someone else and maybe they did, maybe they didn't.
Or even thinking about having sex with someone else while having sex with their partner.
Yeah. So it actually it manifests in so many different ways. And it's also, I suppose, aggression themes as well about whether you are at risk of harming others. So the fear that you could hurt someone else, you could rape them or sexually assault them. Or that
make out with them without consent.
Or
like you might be at a party and make out with someone and then start ruminating, was it consensual? Did I do the right thing? Did they want to stop halfway and I didn't pick up on it? Am I now a terrible person?
Absolutely. And then the opposite, which is like I being worried about harm coming to you and being sexually assaulted by somebody else as well, or harm coming to somebody that you love and that somehow, you know, that strong urge to protect your loved ones.
Yes.
Yeah.
Yeah.
That's sort of –
that's a broad range.
It's a broad range, isn't it?
Yeah, so definitely we need to talk about it. Because look how many places it shows up in.
Yeah, I know. So I think one of the reasons we talked about this before, about the importance of talking about it, is because of how common it is.
Yes.
Because it really does show up. It shows up for kids.
Yep.
Which might shock some people to discover that, but it does.
It does. They're thinking about it.
Yeah. It turns up for teenagers.
Yep.
It turns up for adults. So regardless of what
age
and stage of life your client is at, this could be one of their themes.
Yep.
But also we know that it is one of those taboo topics.
Yes.
It is one of the scarier topics for our clients to bring up with us.
And we'll rarely disclose if you don't have rapport with them.
Yeah.
Yeah.
And so as clinicians, I think we need to be on the front foot with this one. We need to be leading the charge and we need to be really comfortable in this space.
Yes.
So that we can adequately support our clients.
Absolutely, because that's the other thing that happens that we notice, not just as supervisees but as clinicians ourselves, our own discomfort's coming up. When little hints of things might be coming through and our own potential judgment and whatnot that might be showing up in the space. So it's important to be able to sit with that and outright ask the questions.
Yeah.
You know, especially when we're doing those assessments early on, or when, you know, your client's feeling a little bit more comfortable and you're kind of thinking, is there something else going on here?
Yeah.
Or not quite hitting the mark.
Yeah.
Being open and curious about asking directly, are you experiencing any thoughts around, like, you know, what's it like when you go out and when you meet new people, or, you know, when you're being and asking when you're being intimate with your partner, do any weird thoughts come up, unwanted thoughts come up? What does that space look like for you, or just even on the daily?
Yes.
When you're just doing daily activities, like when you're walking past a kid or when you're hanging out with your own family or you see something on TV, what's showing up for you, I think are all important questions to be asking, and allowing our own discomfort to kind of sit to the side in order to be able to do that.
Yeah. I mean, look, when I was early in my career, I was still fairly young, you know, I was in my 20s. And I recognized the need to get my head around these conversations because I work with kids and teens predominantly. And so it was really important that I was able to talk particularly with the teenagers about sex, but also I was working with victims of sexual trauma as well. And so I very rapidly had to confront my discomfort and figure out how to work with it. But the reality was I was in my 20s and I was only figuring out my own sort of stuff at that time. And so it was a really hard thing to be sort of on that personal journey at the same time as sort of helping my clients navigate that. And I like to think now in my 40s that there's literally nothing that I'm not prepared to talk about in the room. Like, you know, like literally like I feel like I've done the work. I've done the work. So, but I can still relate. I can still very much relate to that feeling of knowing I need to talk about something. But I think upon reflection, it would have been obvious. I mean, not super obvious, but it would have been evident to the client that I wasn't like 100%, because I would have been beating around the bush a little bit. Or,
or shuffling around in your seat a bit
talk
more.
About, you know, like, I mean, you know, some people after they've been with someone for a while, like, so, you know, they kind of, you know, they start to think about, you know, like maybe progressing the relationship in a way that is maybe physically interesting. Spit
it out, Tori.
Oh, my God.
Oh, you mean have we had sex?
I know.
That's how usually the answer would come out.
I would have been so
Is that what you're trying to ask
me? I know. But, yeah, so these days, but in the OCD space, I know we've said this before, it is more important than ever because we are talking about clients who are sitting with an enormous amount of fear and shame about what our reactions will be.
Yes.
Enormous self-judgment. And so if we are not truly open, comfortable, willing, leading from the front by asking the questions, normalizing these experiences, having them as part of our assessment, not skipping the part of the why box that includes the sexual themes, asking them just like we're asking any other theme, that we're doing a disservice to our clients.
Absolutely.
Yeah.
And you hit the nail on the head. The more open we are about it and the more comfortable we sit in that space, comfortably we sit in that space, that normalization happens. And that is the thing that allows clients to drop their shoulders, to just lean into it, to go, she's not going to judge me.
Yeah.
Because look how accepting she is.
Yeah.
Or he or they. It's just one of those things, I think, that once that normalization happens, then the shift happens with clients.
Yeah.
And that shift is so important to continue to build rapport, because that way we're going to get more openness, we're going to get transparency, clients are going to feel way more comfortable, and we're not going to be left scratching our head going, what did I miss at session 10?
Yeah.
Right? Because we might be doing some of the work, but things might be stalling, or they don't quite land as well. Because there's something underneath that we're missing.
Yeah.
So it's important to be able to ask that and lead from the front. I agree. Yeah.
How do you do it? How do you work with this? Like, how do you demonstrate your comfort in this space?
Yeah.
How do you show
exactly
that people
how
can
you
tell
described.
you anything?
Yeah, you described it so beautifully. Exactly like that. Like when going through the why box, just asking it as like it's a matter of fact thing. And if I know someone's in a relationship, not shying away from what's the intimacy like? Is it happening at all?
Yeah.
Like, tell me from a normal relationship perspective, but also how does OCD show up in your relationship?
Yeah.
What does it get in the way of? What does it stop you from doing? What is it, what are the worries that are coming up and all that sort of stuff? So outwardly asking, because when we're doing our assessment, we want to kind of really get to know the person, get to know their story, but also when we're thinking about functional impact, it's not just work, school, or friendships and relationships and whatnot. It's also intimate functioning and intimacy, and it's also intimacy with self.
Yes.
Just because someone's not in a relationship doesn't mean that they don't want to explore parts of their body or masturbate or enjoy other aspects of sex and all that sort of stuff. And so, or even want a relationship for themselves or fantasize about wanting a relationship for themselves. So I think not being afraid to go there is the way to do it. Yeah. And I imagine you're you described that anyway.
Yeah. No, I absolutely. So I think just in my psychoeducation, I guess I'm thoughtful about when I'm sort of providing evidence of what triggers could be or what example intrusive thoughts could be. I try to select from a bit of a range, and I always include taboo topics in there.
Yes.
So I don't just go down.
It's a lovely way of doing it.
Yeah, so I don't always go down the pathway of like contamination and, and the compulsion might be that you wash your hands because you're afraid of germs, whatever. Like I'll include things like you might have the thought that, about sex with your father, and you might have an intrusive thought about that happening, and then you might feel the disgust, and then you might have an urge to neutralize, that thought. So by kind of modeling that, I guess I'm inviting them, kind of saying, we can talk about this stuff. This is actually quite normal. In fact, it's so normal that I'm using it as an example in psychoeducation. Yeah.
And the thinking is, if Tori's saying it, then clearly other people have thought about it too.
Yeah. And actually that is something else that I do quite a lot of, is where I'm quite explicit in the early stages of telling clients, I dare you to surprise me. Yeah. Go for it. I bet you can't.
Because there's always this thing, right? We often say this where clients will, and respectfully, because OCD is such a shame-filled disorder that we think we can't speak about it with anyone, that no one else could possibly be experiencing what we're experiencing, that we're completely alone. It's very isolating. And so when our clients come to us, there's this trepidation around, are they going to be able to help me? Have they seen someone else with what I've been dealing with? Are they going to be able to understand? And so when we come out with these examples and go, or even say, I dare you to shock me, it kind of just releases that pressure and allows them to then go, oh, okay, well maybe if they're using it as an example, maybe I'm not the only one that's had these thoughts. Or well, yeah, I am going to shock you.
Yeah.
And then our reaction is, oh, my God, if I had $1 for every time I heard that, I'd be retired by now. And they're like, hang on a minute.
Yeah.
What? Really?
Yeah.
Yeah. And it's like, dude, that's like, you know, OCD 101.
I know. It's so true.
In terms of the taboo thoughts that come up.
Yeah.
It's just that no one talks about it.
No, I know.
Because they're shit scared.
Yeah. And you know what? In a lot of circumstances, like in a lot of like contexts, you might say something and people would maybe kind of think you are strange. Like if you're just like in the lunchroom or whatever, right?
Yeah.
Not in our lunchroom.
Oh, man. The conversations that happen in our lunchroom at work.
We're all quite comfortable.
Yes.
But in the therapy space, truly, anything goes.
Absolutely. Right? So it should be.
And so it should be, right? Yeah. The other thing that I do is I also do self-disclosure about the intrusive thoughts that I've had.
Yes.
And the one that I share a lot.
Here we go.
It's about
take a minute.
A sex dream I had about my brother, which he doesn't know about.
He does now. Hello.
But as you can see, I still remember it very, very vividly.
I can imagine, yeah.
So it was uncomfortable then, it's uncomfortable now.
Yeah, of course.
And I remember waking up in the morning going, what the fuck is wrong with my brain?
Yeah.
What is wrong with my brain? Yeah. What is wrong with my brain?
Yeah.
Anyway, it happens.
Of course it does.
It happens. But I try to normalize by also using that as sort of an example.
Yeah.
Of and also in the room as well. Like when we start talking about sex and stuff, I'll say there have been quite a lot of penises that have popped into my head since we've started talking about sex.
Oh, yeah.
Yeah. You're thinking about a penis right now, aren't you?
Uh-huh.
Yeah. So I use myself as a way to kind of, you know, as an example of just how common it is and how normal, but also that the discomfort is actually also a fairly normal part of the human experience too. That we all have our sort of thresholds for what and our likes and our dislikes, and that is okay, but there's nothing shameful about that. And we don't have to punish ourselves or judge ourselves for this and therefore kind of shut it down.
Yeah.
As that is just fuel for OCD.
100% because it latches onto those values to sink its teeth in even more.
Yeah.
And it does a very good job of convincing us that we're horrid or shameful or dirty or disgusting or just a horrible person.
Yeah.
Just an all-around shit person for having those thoughts.
Yeah.
When we know it's far from the truth.
Yeah, absolutely.
Yeah.
And look, and it kind of makes sense, doesn't it?
Yeah.
You know, that these things, because if we think about kids, and that is probably actually the only space where I am a little bit more delicate. Not because I don't think that kids should talk about sex and things. Like but it's more about I talk about it in a more developmentally appropriate way.
Yeah.
And also I'm mindful that often when you're doing an assessment with kids, their parents are in the room and they may not want to disclose sexually intrusive thoughts. Yeah.
One-on-one time only.
Yeah. So I suppose, you know, there's I adapt it there.
Yeah.
But with kids, they are starting at different ages and stages, but we know that kids experience thoughts about sex and about bodies. Yep. But also we know it's really common for kids to sometimes have uncomfortable dreams about their teachers or their friends.
Yes.
Or they might be sitting in class and have an urge to kiss somebody.
Oh, yeah, that's one of mine. I remember still very vividly being in year 8 and sharing a worksheet with a friend. And, you know, you're both leaning over to share a thing and I would have intrusive images about just leaning over and giving her a kiss.
Yeah.
And then freaking out going,
what does this mean?
What does this mean?
Yeah, what does this mean?
Yeah.
Am I a lesbian?
Yeah.
Yeah. How do I know? I thought I was straight, but now I'm not.
Yeah.
What does this mean?
What does this mean?
Oh, my gosh, my identity's a mess.
Yes.
Yeah.
All the messy thoughts.
Yeah. So kids have these thoughts just as much as adults do. And it's also really common for kids to have thoughts about harm coming to them or others in the set, like, you know, and often I don't know about you, but often the story I hear is like, I need to check the locks or the windows because I'm worried that someone's going to break in and, like, you know, rape me or whatever. Yeah.
So it looks as though, like, if we don't ask the questions, it looks as though checking.
Yeah.
Right?
Yeah.
And harm.
But if we get to the nitty-gritty, we're really dealing with taboo sexual intrusions.
Yeah.
And then adolescence.
Yeah.
Adolescence, I mean, what a classic time
for
this stuff, right?
Because we're trying to figure it out.
Yes.
What do I like? What do I want? We're discovering our bodies.
Yes.
Yeah.
Yes. And so
we're making out.
Oh, yes. And we see so much sexual identity.
Yep.
Sexual orientation themes.
Yes.
Which can be extremely, extremely confusing for teenagers.
But
But then also this is where we see a lot of bestiality, isn't it?
Yeah.
And a lot of incest themes and pedophilic themes sort of start to emerge.
Yeah.
And I think particularly for adolescents who may not have, I mean, it's true for all of us, but particularly we know in adolescence about sort of groinal responses that sometimes seem spontaneous or unexplainable that happen at the same time that, I don't know.
That you have a sex thought about your mum because she yelled at you to put your shoes away.
And then you have a groinal response and you're like, oh my gosh.
God, I want to have sex with my mum.
Yeah.
Yeah.
I mean, obviously.
Yeah.
Yeah.
Exactly. And the other one I think I see creep in, but afterwards, but it still kind of comes through in late childhood, is a lot of the sexual play that happens.
Yes.
When kids are growing up.
Yes.
And then as an adult, start remembering it and go, oh my God, I'm a pedophile.
Yes.
Or whatever else thought that might pop in.
So true.
Yeah.
So true.
Which blends into the real event OCD.
Yes.
Yeah.
Yes. Yeah. Yeah. No, that's so true. Those are hard memories for people to be sitting with. They cause so much uncertainty and doubt and discomfort, don't they?
Yeah. And they're like, should I confess? Do I need to do all these things to make it better and rectify it and prove that I'm still a good person?
Yeah. Well, actually, should we talk compulsions?
Yes.
Yeah.
Let's do it. So, I mean, confessing is one of the biggest ones.
Yeah.
Especially young people to their parents. Yeah. Or people in relationships to their partners. For example, going back to the example I gave earlier around having sex with your partner and then thinking about something else or someone else and then confessing that because you're worried that you've cheated or been unfaithful. Yeah, so confessing I find is one of probably the biggest compulsions in this kind of presentation, and reassurance seeking.
And neutralizing.
Making thoughts, kind of bringing in positive thoughts or avoiding thoughts or undoing it in some way, or kind of completing the scene and apologizing to the person in your mind so that you feel good about it as well. Like, so completing it, I guess. And then obviously jumping on forums, looking for reassurance through forums, chatbots, all that kind of stuff. The other one we often see too is comparisons. So what I mean by that is looking up, for example, someone who's worried about sexual play when they were younger and worried about being a pedophile will then read stories about pedophiles and go, do I have the same personality characteristics?
Yes, I see what you mean. Yeah. Yes.
Or if they know that their friend cheated on their partner, comparing their personality characteristics to that one, going, they did this, this, and this.
Yeah.
And am I the same?
Yeah.
Is that going to make me a cheater too?
Yeah.
So they're kind of doing comparisons in that way. That's another one that I notice. It's a very subtle one though.
Yeah.
Checking for groinal responses, speaking of, so just physical checking and emotion checking. So how do I emotionally feel in this moment versus physically feel is also a very subtle one. So you can see how this can get missed.
Oh, yeah.
Because everything we're describing is basically a whole bunch of mental compulsions.
Yeah, largely.
With very little observable ones, which was the confessing.
Yeah.
And seeing someone go down a Google rabbit hole or a Reddit rabbit hole or whatever it is.
Yeah, that's right.
Anything else that we've missed that comes up for you?
Oh, look, I mean, if we're being honest, it could literally be anything.
It can.
Right? Like it could. They're probably the most common ones.
Yeah.
That and just complete avoidance.
Oh, yeah.
Yeah.
Absolutely.
Probably. But no, I agree. It could be anything.
How do we treat it?
Well, the ERP.
Yes. Oh, and good to know. Latest update. Recent meta-analysis looked at, I'm just sidestepping a little bit, looked at ERP, inference-based CBT, ACT, and exposure therapy is still came up as the most effective treatment for OCD.
Really?
So we're still in good territory in terms
great.
of following. It's not that the others weren't helpful. They are, but ERP is still first protocol. Anyway, so yes, we do treat it with ERP. We can still say that.
Yeah.
That's why I mentioned that.
We should link to that article.
Yes, we should.
Yeah.
I've got it.
Yeah, fabulous. I'd like to read it too.
Put it in the show notes.
Yeah.
So, yeah, head to the show notes if you want access to the article.
Yeah.
Yeah.
I mean, look, we treat this the way we do anything.
Yes.
I mean, that's the thing about ERP, right, is that, the themes themselves give us indicators about where our clients are at, what their experiences are, what their inner world is like, what they're grappling with.
Yeah.
It's opportunity for rich discussion, and also sort of psychoeducation and normalization of this human experience and all of these things. So the themes themselves and sort of the beliefs attached to it and the identity and stuff, like that's all rich. But when we come down to the actually, like, how do we increase
the mechanism of treatment?
Increase your functioning and decrease your symptoms. Yeah. It is the same regardless of what theme we're talking about, which is expose yourself to the triggering, situation or thought or whatever, and observe, the thoughts, the worry beliefs and the emotions that come about, and resist the urge to engage in your compulsion.
Yes. Expose yourself to sex.
Expose yourself to sex. Look, but this one's hard. I mean, look, they're all hard. They're all hard.
Yes.
But I think because of the nature of just how intimate the theme is, but also, I mean, look, I don't know if it's any harder really. I mean, they're all like, if your nervous system is firing.
Harder, but I think, exactly. I think it's all relative, right?
Yeah.
Exactly. Like, I think it's all relative. It's not that it's harder. It's just sometimes a little bit more delicate.
Yeah.
Because there's so much tied into it.
I know.
Especially when it comes to our own sexual identity and what that means for a lot of people, especially if there's trauma involved. That's a whole nother layer.
Yeah, absolutely.
And so we need to tread carefully there. But it's just one of those things where it's a little bit more delicate. So it's not, so in answer to the question of, are you going to be able to treat my OCD? The answer is yes. It's just how we go about it. There'll be little nuances along the way.
Yeah.
Considering trauma.
Yeah.
Or maybe using scripts a little bit more. Because it's not like you can simulate having sex with your partner in the therapy room.
You can't?
I mean, that's probably where I draw my boundary.
No, that is a hard no.
Yeah.
No, you're right. So some of the exposure work has to happen at home.
Yeah.
For sure. But
so
you're right. But
there's like little nuances.
But especially given that a lot of what the intrusive thoughts are about actually is separate from the realities of sexual intimacy.
Yes.
In that it's the fear of who we are deep down, about our morality, our ethics, our
character.
About, absolutely. And so it's, I think where it shows up in actual sex is probably more in relation to sort of bodily avoidance of bodily fluids, fear of sexually transmitted infections. But also I think people sometimes start avoiding sex because they're afraid of what will pop into their head during sex or masturbation, and so they start to avoid that altogether.
Which is what you work with in the therapy room.
Yes, that's right.
That's the component. You don't actually need to –
No.
Your client's imagination is going to do the work for them. Let their thoughts go there to the same places that they would when they're having sex.
Yeah.
Or whatever else it might be.
Yeah, but with some of the other themes, it's really just about like any other theme, which is exposing yourself to the worst case scenario through script work, through imaginal exposure, story writing. I use the whiteboard a lot.
Pictures, trigger words.
Absolutely. Just writing it down, writing it over and over and over again whilst, observing the thoughts, observing the feelings, regulating and grounding through it and allowing the wave of fear and distress or disgust or shame to pass without engaging in a compulsion. Yeah. So there's lots of work that can happen in the room, and then it's about sort of, I think, navigating how does this show up in the world outside of the therapy space, and how can you continue to keep this good work going? Because I find with teenagers, they're often really afraid to do exposure work at home. They often don't want to tell their parents about the themes of their OCD, which is fair enough, which means that they're not going to want to keep necessarily a logbook of what their exposure is. Their parents will often ask what's for homework, and they won't want to share. They can often be a little bit resistant to it. So I think just, good, collaborative kind of care, find a way to make it work.
Absolutely.
Or even if a young person is saying to you, like, I just can't bring myself to actually like sit in my bedroom and write a story about having sex with my brother, for example, that is okay. Yeah. Fair enough.
Absolutely.
But what you might be able to negotiate is, okay, sure, but let's say you're hanging with your friends and the thought pops into your head and you were having a great time and now you're having this incredibly distressing kind of emotional response and you just want to go and hide yourself away or call your mum to come get you.
Yep. How do you resist doing that?
that?
Yeah. Which leads me into what the thought that I was holding on to, which is one of the ways to help encourage clients to lean into the discomfort of this space is using their values and what they want to move towards to help them do that. And that's a perfect example of that. So for example, hanging out with my friends. And if the thought pops in while I'm doing that, when I want to stay and hang with my friends, then I need to stay in that discomfort.
Yeah.
Or if I'm not in a relationship, but I want that for myself, but I'm terrified of what sex might mean and all that sort of stuff, how do I lean into these exposures to help me move towards having a relationship for myself one day?
Yeah.
And so on and so forth. So I think that is a really helpful way to encourage clients navigate the delicacy of the space and the trickiness of the space.
Yeah.
And be able to expose themselves to sex.
Yeah. Anything else? I mean, we haven't really talked about trauma. We've talked about that in separate episodes. Yeah. I think it is something to definitely be mindful of, and that is why we say as ever that, even if your client comes to you already diagnosed with OCD, you still need to really understand the person.
Absolutely.
And do a thorough assessment.
Oh my God.
And understand their
Don't ever skip that step.
No, their whole story.
Yes.
Not just the OCD symptoms, but
the whole picture.
The whole picture. You've got to do it.
Tell me about you.
Yeah. So we've said that time and time again because, OCD is more than just a bunch of symptoms, right?
Goodness, of course,
and people are more than their OCD.
Yes.
So if you are talking about someone who has a sexual trauma history and they also have sexual theme OCD, then I think
which is very likely.
Yeah, very likely.
Yeah.
Then I think what we've got to do is we've got to, I think, often work at a slightly slower pace.
Yes.
We've got to make sure that they have a really good foundation in grounding and regulation.
Yes.
That they have adequate window of tolerance.
Yes.
And the ability to move through exposures.
And dysregulation.
Yeah. That it is truly a safe environment.
Yes.
And that it is very, very collaborative and that you're doing a really good job of sort of negotiating which aspects of their OCD they want to work on, and also distinguish between intrusive thoughts that might actually be flashbacks.
Yes.
Or re-experiencing of trauma versus what actually might be ego dystonic, OCD sort of related thoughts and obsessions
coming up in the present moment,
because they get attended to differently.
Of course they do,
and so you've got to kind of really know what's speaking to you in the moment, what's showing up for this client in this moment, and so
that's a really important distinction.
So that you kind of think very thoughtfully about how to navigate each, because they require different approaches.
They do, absolutely, they do.
Yeah,
I think the other thing that can be really helpful is to kind of help set the client up for success when there's trauma involved, is helping them map out what's what from the perspective of helping them understand the patterns of trauma and how that's showing up, so that they can identify what's a flashback versus what's an ego dystonic intrusive thought, as well as understanding how OCD shows up when trauma gets triggered. And how it's trying to protect them in the moment, but really it's that maladaptive coping strategy.
Yes.
And so how can we then bring in all the tools they're learning to help replace that too?
Yeah.
So I think spending that time in psychoeducation is necessary, but I think you need to spend longer in that time to really understand what's going on, not just for you, but also for your clients. So you're kind of formulating together and understanding the patterns, and they're trying to learn how to pick them up too, so that when they're doing the exposures, they have more control. Yeah. And that sense of autonomy.
Yeah, I agree.
We've covered a lot of ground.
Yeah. Is there anything else? I don't think so.
Nothing that comes to mind. I'm sure our listeners have 10 million questions.
Well, look, I also, actually, my last My last comment would be have some fun.
Yes.
Be playful.
Yes.
Just because the topic is sex doesn't mean it has to be serious and conservative and quiet and, we can be playful in this space as well. And actually, I think that and not playful because you're uncomfortable and you want to laugh your way through the awkwardness. But, I suppose that happens sometimes. But, just this is a space to play just like any other.
Yes.
Yeah.
Yeah, absolutely. Amazing.
All right.
We hope you found that helpful. We'll catch you in the next episode. Thank you so much for listening.